All right. Welcome, everybody. Hello and good evening. I'd like to welcome any new participants we have joining us tonight, as well as welcome back any returning participants. Before I introduce myself, I'd like to point your attention to the poll on your screen. You could just answer that question while I introduce myself. So it's my pleasure to welcome you all to tonight's virtual grand rounds presented by the American Academy of Developmental Medicine and Dentistry. My name is Michael Tarr. I am a second-year medical student at New York Medical College. I am the AADMD Virtual Grand Rounds Facilitator. So let's take a look at our first poll. We have, the question is, which professional role do you represent? And tonight we have 25% of our participants joining us are working in administration, 44% are working in medicine, 6% are working in dentistry, and 25% are working in other. So the AADMD Virtual Grand Rounds seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. I'm just going to pull up the second poll, and you can answer whatever you'd like. So at the end of the session, we'll send you a link to a quick survey we've made, and it shouldn't take more than 5 minutes, but it's very important to us that you do fill it out, because the feedback we receive through this survey allows us to improve the virtual Grand Rounds experience, and also to hear what future presentations you'd like to have us organize. So let's look at this poll. So the second question is, in what stage of your career are you in? We have 93% reporting that they are currently practicing. 7% said that they have retired from practice. Just one more poll. So tonight our presenter is Dr. Potts. Dr. Potts received his Doctor of Medicine from Howard University College of Medicine in Washington, D.C., where he served his internship and residency in internal medicine and a fellowship in gastroenterology. Dr. Potts is Corporate Medical Director of ResCare Incorporated, a healthcare services company that provides residential and home care to seniors and people with disabilities. Dr. Potts' experience is multifaceted. His 30-year practice includes 15 years working in home care and residential care and more than 20 years in administrative leadership positions for a broad spectrum of populations, including people with intellectual and developmental disabilities, seniors, and disadvantaged youth. Additional experience includes emergency room, urgent care, clinical quality assurance design and implementation, mortality reviews, infection control team oversight, development of chronic care protocols, and cooperation with legal teams in review of institutional malpractice defense initiatives in the public and private sectors. So with that said, during the lecture, if you have a question or want something clarified, use the question feature, type out the question into the chat box, and I will relay the questions that are immediately pertinent. But most of them will be saved for the end of the lecture, where we'll have a set time dedicated to answering questions. If you are joining us tonight, you should have received an email recently that has the lecture slides in them, or the presentation slides in them. So feel free to download those and follow along. If you did not receive this email, you can check the handouts button on your gray box on the right side of your computer, so you can continue to download the slides from there. So I'll just go over our last poll, and then I'll hand the floor over to Dr. Potts. So for our last poll, it asks, what do you hope to gain from this webinar? 24% said learn foundational healthcare concepts for individuals with intellectual and developmental disabilities. 38% said gain interprofessional perspective on healthcare for individuals with IDD. And 38% said gain pearls from complex and challenging clinical cases. All right. And with that, I'll hand the floor over to Dr. Potts.
Thank you, Michael. Good evening, everyone. Thank you for taking time out of your busy schedules to join us this evening. As Michael had indicated, I have a background in internal medicine and gastroenterology, and I've been working with this population for about 15 years, which included private practice, working group homes, being a medical director, and now corporate medical director. Tonight's topic for discussion is risk stratification and triage challenges in the AADMD population. The key point here is that we are hardwired for pattern recognition. And whether we're students or we are out in practice or we're attending grand rounds or we're keeping up with our various specialties or following what is going on politically or socially or economically in the healthcare environment, we're looking for patterns constantly. Now, that pattern recognition has some differences with the population we serve as compared to mainstream population. And all of us sharing our common experiences with this will improve health outcomes in general. So, descriptive and prescriptive assumptions affecting clinical outcomes, data reliability for predictive modeling, and useful tools to mitigate risk are all of the things that we'll touch on this evening. So keep in mind, we must be silent before we can listen. We must listen before we can learn. We must learn before we can prepare. We must prepare before we can serve, and we must serve before we can lead. That's good advice, and it works well with medicine. So our objective in the virtual grand rounds tonight are an opportunity for us to listen and learn from each other so that we can better prepare future generations of students and stakeholders to better serve the needs of the DD population and for each of us to progress from being students to teachers and when needed to become leaders in the challenge to end healthcare disparities in this population. Now, typically a grand round structure would be a patient presentation, and I noticed that about a third of the individuals that signed on are interested in identifying how to work with clinical and complex issues, etc. We can touch upon some of those, but we really want to go into some of the root cause analysis that will help you build a repertoire or an approach to a patient that will help you work through those complexities yourself, whether you're a student or whether it's new to you out of private practice. Now, ordinarily we have a history, a physical exam, differential diagnosis and diagnostic studies, a past report, and in the end, what lessons have we learned? So let's start by reviewing some facts. 15 to 30% of this population have epilepsy, 25 to 32% have a co-occurring psychiatric disorder, though frequently misdiagnosed. The chromosomal abnormalities that cause DD represent the highest frequency cause of infant mortality. Now, since the 1930s, life expectancy for a person with DD has tripled from roughly 20 years to approximately 60 years. Now, what's embedded in that we will touch upon later as an assumption with deinstitutionalization, which brought some of its surprises that weren't anticipated. So fewer than 10% live past 65. For the first time in human history, more adults with DD than minors with DD, and medicine and health systems never anticipated this type of demographic shift. So we are in the pounding surf of change, and all of us collectively have a role to play in keeping the healthcare upright. So at an average age of 24, 15% have osteopenia, 5% have osteoporosis. 12% are in active dental pains, 47% with untreated tooth decay. 70% are obese or overweight, 32% will fail a vision exam, 27% are not properly corrected, 20% have a hearing deficit, 4% require a hearing aid, 25% have ingrown toenails, 11% have fungal foot infections. Now, when you look at this population and you put all of these things together and add to it some other factors, it becomes a very challenging population to work with. In fact, you might say it is the most challenging population to work with in the healthcare. So polypharmacy due to inappropriate diagnosis and care. 25% more likely to be given a prescription. Now, why is that? In practice, with the pressure of time, very often there is an expectation that either the caregiver or the individual will not be satisfied unless they're given a prescription. The other thing becomes trial and error. Well, let's try this prescription and see what it does. Now, if it seems they come back and there's no problem, then 300% more likely to have that medication repeated. That is probably something that we need to work on. So the 46% that are given a psychotropic med, 1/3 of the cases they don't have a diagnosis to go along with it. In other words, we're treating behaviors empirically, and they may have a somatic cause. So you end up putting one medicine on top of another medicine, on top of another medicine, treating side effects, and we haven't gotten to the root cause of it. So the good physician treats the disease, the great physician treats the patient who has the disease. Now, certainly that is something that resonates well in the care that we intend to provide for this population. That 81% of the graduating fourth-year medical students have never had any formal training in caring for a person with DD. The remaining 19% average less than 1 hour of clinical experience. And more than 90% of internal medicine and family residency programs have no formal training of their residents. Now go back to the idea that 30 years ago, the average life expectancy was 20 years of the individuals when they were in the institutions. Well, by 20 years, with a life expectancy of 20, you've never really left the pediatric office or pediatric care of a pediatrician. So internists really didn't have much experience or exposure at all. I know mine was minimal. So what is the end game? What are we trying to get to? One view of this is the AAA. Improved population health, improved individual quality of life, and lower cost. This phrase that follows is important in terms of how we achieve that. Success is attainable, success cultures. The word culture is different from training because cultures encourage you to absorb concepts and set expectations, whereas training merely sets reaction patterns. And what do we refer to when we talk about medical education? It's training, physicians in training. So it sets reaction patterns. It goes back to being hardwired for pattern recognition. Now there are subjective factors in that while we're even in medical school that affects what it is that we do later and how we interact with this population. So looking at the cost end of it, this is a 2013 summary of what it costs at the various levels. You can see waiver cost per participation is $44,000. The lowest cost, family support programs. Highest cost for state institutions, and most of them are closing now. So when we look at the trajectory in terms of costs, we know where it's headed. There are about 400 waiver programs, which is quite a bit. And we start out with large ICFs, and then smaller ICFs, and then group home settings and waiver settings. This is the direction that we're moving. And when we look at the AAA, we're looking at lower cost. Now, it's also intended to provide an individual with better quality of life. So William Osler, the person who takes medicine must recover twice, once from the disease, once from the medicine. So when we look at the healthcare system and we look at who the person is in this case, so we're looking at the ID population, for example, or the DD population, and the medicine that was prescribed was institutionalization and then deinstitutionalization. Moving forward, this is 1915. chloroform unfit children. Show them the same mercy that is shown beasts that are no longer fit to live. Now, this is a mindset that is very aggressive or indifferent by today's standards. And look at the value assumption that is implicit here. With a reference to an agrarian culture, going back to culture, you see that individuals are considered to be contributors to society to the extent that you can become part of the workforce, labor force, hold your own, so to speak. It's a mindset as though the value of an individual is tied to their productivity within a particular type of work environment. Now, moving forward to 2007, this is a study that was done in the United Kingdom that evaluated a number of hospitals within the United Kingdom with the outcomes of treatment for people with developmental disabilities. And the significant findings here, after they looked at 72 hospital deaths, they concluded that the deaths were caused by indifference. The excuse that was given was that we're not geared up for people with a learning disability. The findings were a lack of basic care, poor communication, delays in diagnosis and treatment, failure to recognize pain, and DNR orders. Now, that was the United Kingdom. The study was repeated subsequent to that with not a great change in outcomes. And a few years ago, there was a small study in this country which showed the same conclusions. Now, research setting, 2007 to 2011, is a consistency of findings spanning over 30 years of research that points predominantly towards a better quality of life for people in community settings compared to living in institutional care. 2013, 50th anniversary of John F. Kennedy's Community Mental Health Act. That same USA report included the 1963 law had the unintended effect of releasing people committed to mental institutions into communities that were unprepared for that. That is the reality that we're living in today, or the recovery from the medicine of deinstitutionalization. It is a challenge that collectively we're working to resolve, and it takes clinical and non-clinical advocates as well to change the trajectory of it. The current structure of the American health insurance company makes it more difficult for people to receive mental health treatment. And we know that, those of us who are in practice. Now, when we look at what was going on in the institutions prior to deinstitutionalization, you had a direct support person. That direct support person was working within the context of someone else doing the shopping and handling transportation, providing recreation, cooking, social work, a secretary, business, you had nurses, and a maintenance department. Now in the community, the DSP, now the shopper, handles transportation, does the cooking, handles maintenance, interacts with the business community, does the answering of the phones, works with all of the nurses, and does the housekeeping. That's a different kind of a shift. And that is, when you combine that with what the nurse in the institution was doing, such as goal planning, supervising LPNs and NAs, they had other supports. There was a QA department, case management, medical records management, etc. So the nurse, outside of the nursing duties, had a system of support that handled a lot of the other logistics. Now, putting the nurse out in the community, where you have nurses, because some operations do not have nurses, some programs don't have nursing, it's not funded. And in some cases, the ratio of nurses to patients is well beyond what it would be in an institution. So now the nurse is responsible for all of these things, conducting the assessments, urgent conditions, changes in CPR, health teaching, providing skilled nursing procedures, coordinating the orders, handling the medical records management, interacting with case management, responsible for the documentation, etc. So when we look at institutionalization to deinstitutionalization, there is an expectation or an assumption that the nurse, because she was in that environment, is capable of absorbing these other functions with the same ability to control outcomes as she did with the other supports in place. Now, in some of the toughest scenarios, you have a nurse who is now interacting with multiple DSPs who are carrying on the functions that supports were originally provided. So it becomes very complex in terms of how this care is delivered in the context of the clinical and administrative function in a deinstitutionalized arena. So, some of the studies indicate that there are two factors that affect judgments about the impact of living arrangements and outcomes. Strong association with the personal characteristics of the individual, and in particular, the cognitive level and adaptive behavior. Now, this is important as it relates to training. And the reason that this is so important where training is concerned is that when you go back and review where we were and even where current medical education is, our systems are so dependent on an individual being able to self-report. How much attention is actually paid to how do you interact with an individual, such as a comatose patient or the unconscious patient? It's a shift in focus. So when we look at disparities now, the differences in the incidence, prevalence, mortality, adverse health conditions that are existing among specific population, that's the NIH definition. The World Health Organization, abilities that are considered unnecessary, avoidable, and unfair or unjust. Going from the negative to the positive, how do we define equality? It's attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally, which you can see the distance of this wording from Clarence Darrow, one of the foremost defense attorneys in the legal profession. Very different perspective. It requires valuing everyone equally with the focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Thanks to Mary Foley and our recent strategic planning session introduced this slide. Once you see this, it's really difficult to misunderstand the distinction between equality and equity. Equity is what we are trying to achieve. Deinstitutionalization, one of the challenges was that the assumption was that you could put individuals into the community and they can access the healthcare system the same as everyone else can. But the equality of access was not exactly the same thing as equity in opportunity to receive healthcare. So, one of the prescriptive assumptions, which again goes back to the comment by Clarence Darrow, is ability bias. And ability bias is the assumption that able-bodied people are the norm in society, and that people who have disabilities must either strive to become that norm or should keep their distance from able people. Two examples are given here. One of a bias. Our institute is dedicated to reducing the burden of people with disabilities on their families and society. The alternative is our organization is dedicated to providing people with disabilities therapies that improve skills and functions. Now, the second is the consciousness that we are trying to, or that we are actually advocating to improve outcomes with the population we serve. Now, ability bias, we may think, or yeah, that's fair enough, we may think that we are free of ability bias, but ability bias is very subtle. Ability bias, even in medical school, shows itself in the subtle decision or distinction in the type of medicine that we choose to go into, doesn't it? There are, in this country, in a recent census of physicians, 177,779 internal medicine physicians. Family medicine or group practice, about 127,000. There are 78,000, by comparison, pediatric physicians. And peds dentists, about 3,000. Now, some of us who chose to go into adult medicine made a decision to not do pediatrics because in pediatrics, very often children will not communicate. We want someone who can tell me what's wrong. Where does it hurt? How do you feel? You know, we're very promptive in our way of obtaining information. The history and physical gives us 90% of our diagnosis that we confirm with the studies that we do. So we may not think of ourselves perhaps as having an ability bias, but it shows up in very subtle ways. So in the process of providing medical education, what is it that we need to do to not necessarily ensure, but to cultivate the alternative to bias? Even in the part of our training, when we look at objectivity, we obtain a history. How much training do we actually provide in how do you assess the individual who is not able to self-report? There are more and more people in our communities, whether we are referring to a pediatric population or a geriatric population with the elderly, such as Alzheimer's, etc. And there are very few geriatricians. And that need that is a skill that can be developed. Now, there's a natural talent that some people have, and those who become pediatricians, it's marvelous to watch them work with kids, how they get kids to open up, and how they work with parents to obtain the information that is needed to come to a correct diagnosis. So this is a very important foundation for us to consider. We get put into a room of individuals who are not able to self-report. How good are diagnostic skills? Where else does this play out? This plays out in the emergency room. Very often, in sending individuals to the emergency room, they will either ask the individual what is wrong with them and take that answer because of the culture that says, well, what the individual says, I need to write down and I can work from there. There's a caregiver with the person. Sometimes the caregiver knows, but are they listened to? Very often I've had to intervene because the emergency room physician is not necessarily paying attention to the cues that the caregiver is providing related to the overall health of the individual. You don't get all of the answers from the CDC and the UK. You can get good information, but it's not the whole story. So internal medicine family practice, there's a lack of disability training and experience. We need more training and assessment of the nonverbal patient. There are communication barriers with caregivers. Sometimes that's a language barrier. Sometimes it's the assumption that, oh, the physician knows best. There is an overdependence on self-reporting and constraints of reimbursement models and an ability bias within the practice. In other words, the individual ought to be able to communicate what's wrong with them. And if I can't rely on that, I'll just get some labs. We'll do something empiric, follow up with your PCP, or we'll get the labs back, but everything looks fine. So it must just be a behavior, referred behavioral health. Now, even in the community, we have community response teams that are subject to these same kind of challenges. And I'll give you an example of a case of a 53-year-old woman who would be cognitively moderate. She took direction easily. A very emotional person, often tearful, high anxiety. Nevertheless, she was able to be directed if you needed to. She had a fall down the stairs, and the EMTs were called. And as was customary for her, she was tearful, had some stranger anxiety, and did not wish to go with the EMT team. So they decided not to transport her based on, quote, her vital signs are stable, and she says that she doesn't want to go. Now, later that day, she didn't eat her lunch, and at dinner, she didn't get up for dinner. Several hours after that, with the change of shifts, caregiver became concerned and sent her decided to call the hospital, or call the EMTs again, and send her in. And within 24 hours, she had died from a subdural. Now, that's a case where the culture within a home would be to follow the information or the directive provided by medically trained people. The medically trained people, in turn, were dependent on self-reporting and overly dependent on objective factors such as the vital signs. Even though the nurse, when she was called, said monitor her for changes in behavior, you have people in the front line in a direct support position that really don't know, how those assessments, how to make those judgment calls as efficiently as you would within the clinical system. And there are many examples like that. An individual who had a seemingly minor fall in the bathroom was assessed by a nurse. Vital signs were stable. They decided to monitor for a few hours. The individual had Down syndrome. They also had atlantoaxial instability and ended up with a fracture of C1. By the time he got to a hospital because of the change in behavior, his spinal cord was transected, and within several days, T2 had died. So some of the assumptions and dependencies that we have are not, let's say, acute enough, not sensitive enough to pick up some of these, create some of these algorithms for assessment. Law enforcement can be the same. We have some individuals, because of behaviors, will like to leave their facility, and there are laws and rules against restricting them. And some places you're required to notify law enforcement. And the sheriff in one small town said, "Why do you keep having this problem? Why don't you just chain him up?" So some of the attitudes that we have are, we have a long way to go to change how the community reacts and interacts with our population. And we as clinicians and advocates and lawmakers, policymakers, need to recognize what it is that we have as a challenge to create these protocols to provide the community supports that lead to equity, because it's not entirely an equal playing field out there. So emergency room factors, again, lack of disability training or experience. There's assessment in patients of erroneous descriptive and prescriptive assumptions related to residential settings. Now, where does that come in? Very often we will have treatments provided in an emergency room that cannot be managed in a particular residential setting. And often there is the assumption that it's a clinical setting, when in fact it isn't. And for example, if you have someone where you're in a home, a residence, where the bedrooms are upstairs, and you put an individual with cognitive impairment, moderate to severe, on crutches, there's absolutely no way you can get the individual safely up and down. And some of the supports that are needed, if you have that kind of a situation, working with the emergency room or the hospital, we need alternate solutions to provide supports in an intermediate manner to reduce the risk of individuals creating more injury. Unawareness of some of the health risk factors, limitation of physical exam technique and illness presentation, such as altered pain thresholds. So let me give you an example of that. And so many of us who have had this taking care of individuals in the community know this to be true. You have an individual, there was one particular individual I recall who fell in the bathroom trying to put his pants on. And the caregiver went in there and saw him on the floor trying to put his pants on and asked him if he was okay. He said yes. Well, she watched him as he was trying to navigate the clothes, and he was different. It's not the way he would ordinarily do that. So having some index of suspicion, she left him there, called the EMTs, and had him transported to the hospital. And sure enough, he had his pelvis was fractured in 4 places. Now, he showed no outward signs or symptoms of what, for the most part, would be considered a painful experience or event, certainly for most of us. And it is one of the more incredible challenges that we face, not just with this individual, but in many other cases. There was an individual I encountered at a day program, and I knew him well for a few years, and customarily he would shake my hand. But he had some restriction of his movement, and I asked him if anything was wrong, and he said no. Do you have any pain anywhere? And his answer was no. He was passive, as probably many of you are, on the other end of this line. So I had him take his jacket off, and palpating his deltoid region, I could feel the deformity. He sent him in for X-ray, and he had a clean fracture just below the clean fracture of the uterus just below the neck, and never evidenced any discomfort at all. Now, I know the woman who was taking care of him, and I called her and said, "Are you aware that he has a broken arm?" She said, "I had no idea." She said, "Well, he fell down the stairs a couple of days ago." I asked him if everything was okay. He said, "Yes." See how accustomed we are to self-reporting. This altered pain threshold is almost enigmatic, and I don't know if there's anyone online that can shed some light on that. But we have no way of knowing who is and who isn't necessarily until something happens. It is not universal across the spectrum. Certainly there are those who get hurt and indicate it either by verbalizing it or by behavior, but then there are those at the other extreme who seem to have no awareness of it. Not sure if everyone is still with me. Let's see. Now, let me give you another example of an individual or a situation where there was an unexpected awareness of pain, a variation of pain. I was assessing an individual as I had on a monthly basis, and I was listening to his lungs. I looked down, and it seemed to me that his abdomen was protuberant. So instinctively, I put my hand on his abdomen, and it felt tense. So I immediately went to an examination of his abdomen. And I asked the caregivers, and they told me that it was always like that. I asked him if he had any pain. He didn't indicate, so he was as comfortable as he usually is. As a gastroenterologist, I was convinced there's some abnormality. Sent him in for an X-ray, and sure enough, he had a volvulus. Now, they reduced the volvulus and sent him back to the facility. And going through archived records, found that he had had an identical volvulus 6 years prior to that. I advocated for surgeons to intervene, and it's not commonly, if it's reducible, there seems to be reluctance to doing that. And with again, the prescriptive assumption that if it happens again, an individual ought to be able to indicate that they're in discomfort, an assessment would be made, and reduction would be attempted, etc. Well, eventually that group of patients went to another physician, and a year later I was invited to his funeral. He was 32, and what had happened was, apparently, even though the staff there was trained to be vigilant for distended, tense abdomen, regardless of any complaint of pain, that he would be referred for an evaluation. Well, it occurred on a Friday night, and the weekend staff weren't as aware of what his typical presentation might be, or were certainly not alert to what this might represent. And by Monday, when the regular staff came in, it recognized that he was not at his baseline for behavior with the distended abdomen. By the time they sent him in, his bowel had become so necrotic that he was inoperable. So these are some of the challenges that we face with individuals who have altered pain thresholds. So in the hospital, we certainly are still dealing with ability bias. We have minimal risk awareness, familiarity with the risks associated with this population, lack of communication protocols. Now, communication protocols is how do you identify, how do you set up or communicate with individuals who have communication challenges. In some cases, we're allowed to have advocates or caregivers stay with an individual and somewhat be interpreters of behavior to interact with the medical community within the hospital. In other cases, we don't have that. The tendency to expect self-reporting, once again, is an unfortunate bias that can lead to adverse outcomes. Another example related to GI and bowel obstruction is an example of an individual who had a volvulus on a Friday. It was reduced. The decision was made to for surgical intervention on Monday. Well, they didn't examine his abdomen from shift to shift, and he wasn't self-reporting. And by the time it came, by the time Monday came, he had died late on Sunday because the volvulus recurred, was unrecognized, and the bowel had become necrotic, septic shock followed, and he died. So a lack of standardized consent procedures. This is a significant problem within the hospital as well as the emergency room. The regulations that don't allow for an individual's information to be communicated to caregivers when they go back or leave the emergency room, come back to the facility, or leave the hospital, we end up with providing information that is so generic it doesn't help us to manage the individual within the next 24, 48 hours, or however long it takes to get the actual reports. And case in point, you get a call in the middle of the night and an individual has had a seizure, so you send them to the emergency room, and you get a couple of hours later, they're back from the emergency room. Okay, what did they find? You say, yeah, seizure. Well, we know that. But what did they do? Well, they gave some IVs. Well, what did they give me? What did they give me the IV? Well, they didn't tell me. They didn't give me the paperwork. They did labs, so it was a level high, it was a level low. To get an IV in order to get additional medication, it was Percocet. You get antibiotics and that. So all of these delays in treatment, these barriers that we have for communicating what is going on, they need to go away if we're going to be able to manage this population in the same way we can manage the mainstream population. Discharge planning biases, they create challenges for us. Typically, well, unfortunately, sometimes you get patients being discharged on a Friday and you need to put supports in place. And you can't find a pharmacy, medical supply, housing, or even making bed arrangements to get them from a higher level to a lower level in a timely manner. So we need to improve our perception of the needs of this population, because treating the population the same as mainstream is maybe equal, but it is not equal. And what do I mean by autopsy indifference? Now, autopsy becomes very important in terms of the information that can be provided that can allow us to make different decisions regarding how we manage populations. Now, unfortunately, certainly my own experience has been very often we don't get autopsies. Now, from a provider community perspective, once an individual passes away, we're not entitled to any more information. And it becomes a real challenge to find out what the autopsy showed. In many cases, we don't get autopsies. Same thing with death reports. 50% are unreliable. To give you an example, an individual going in, he's in his 20s, they decided to put a tracheostomy and a feeding tube in because complications of oral pharyngeal dysphagia and recurrent pneumonia, and the individual does not come out of the anesthesia, and it's called death by natural causes. Well, how does that help us moving forward regarding the individual's risk for going in for an operation? And is that in fact a natural cause? Now, hospitals will elect to not do autopsies because the bias of, well, what can we possibly learn from this unique individual? Well, this unique individual is part of a family of unique individuals, and we need to understand what the challenges or changes are that affect the outcomes. One of an alarming example of this is that there's an individual who is high functioning and very gregarious, constantly chatting. He's on the way out in the morning to a day program, and he's chatting the whole way, as he typically does, about things going on in the street and talking to the other folks in the van. When they get to the day program, so it's kind of noticed that he's quiet. So they start taking folks out of the van, and when they get to him to come out of the van, he's passed away. We have no idea. It was just that sudden. So, in the absence of an autopsy, what was it? Was that something that could be managed differently? That is a type of indifference, and it is a barrier to achieving the population health outcomes that we would like to, because the information that can be provided, be it cardiovascular, metabolic, or gastrointestinal, these things are all important for our population as it is for the mainstream population. So we as clinicians must advocate for this. And as caregivers must advocate, because that is a contribution, that individual's life matters, not only while they are here, but the information that we share, the things that happen to us when we pass away, is also important for considering where do we go the next time an individual has a particular set of comorbidities. Now, here's a sample of some data, age and death distribution. It's a comparison of 2013 deaths to the U.S. Census population. The blue line is the U.S. For those of you out there in radio land, if you were picturing a sliding board with the stairs to your right, then there's a gradual slope down towards your left with higher age decreasing to lower age. And there's a second curve like the hump of the back, hump of the camel. It's in the middle of the graph, which peaks about 55, 56 or so. So when you look at these two line graphs, you see that they are markedly different. So when we talk about disparities as prevalence, outcomes, morbidities, etc., well, this is a visual representation, and we do have healthcare disparities. Now, and this is based on age. This is the same population with causes of death, with highest frequency to lowest frequency being the blue bars, and a Medicare, Medicaid population. And the red bars are deaths associated with the DE population. Markedly different. What do we see with the highest causes in the mainstream population? Number 1, cardiac. Number 2, cancer. Number 3, natural causes. Number 4, respiratory. Number 5, stroke and diabetes, renal failure, etc. Now, with our population, the highest is pneumonia and respiratory. Moving down to 1, 2, 3, 4, 5, 6, 7, 8, 9. Ninth leading cause in mainstream is the fourth leading cause is sepsis in our population. So we have sepsis, pneumonia, and respiratory diseases as leading the cause, leading the pack. Now, look at stroke, much lower in our population in terms of causes of death, diabetes, renal failure, accidental suicide, etc. So there is a distinct difference. We see high cause with seizure. Now, realizing that cause of death is written on a death certificate that may come from a hospital, we have some reliability issues related to that. But these categories were pulled from a population that I reviewed each of these cases and have described their cause of death to that. Now, it's significant that pneumonia and respiratory, as well as sepsis, as high as they are. Infection, very important, very high incidence in this population. And part of that is related to oropharyngeal dysfunction. Now, that in turn leads to control of the oral environment, which takes us to dentistry. It's very important that we have integrated health care concepts, because the biofilm of the mouth, if it is not managed, creates a situation with silent aspiration that leads to pneumonia, and based on the triage skills, may not be recognized until it is too late to intervene. Now, this same population, and now what we have is a dotted line. The dotted line, which is over the peak of the 55 to 64 age range, is significant. Remember from the MenCat report in the United Kingdom, DNR was listed as one of those causes of death by indifference. In our population, in the populations that I have studied, 30% of the individuals who come to the emergency room with a serious illness end up with a DNR. DNR is do not resuscitate, and depending on what state you're in, it may be called a comfort 1 or a post. But the bottom line is one of two things. Either because of the recurrence of illness of the individual, it is decided that we're just going to let nature take its course and not intervene, or individuals get to emergency intervention too late for intervention to prevent their demise. It's one of those two factors. Now, in some cases, we have caregivers who advocate very strenuously and have turned some DNRs around, and individuals have actually come out of the ICUs and the CCUs and off of respirators and are still alive today. So I don't think we should ever stop advocating. A DNR should not be imposed for systemic convenience or for some misplaced ideas of that have their basis in a bias that, well, the individual is only going to get sick again. And that is literally some of the things that you hear as you go along the way. So the top 5 ER referral diagnoses. And this is some morbidity data that I worked on this past year. The number of cases I reviewed is about 4,500. Accident and injury accounted for 40%. Respiratory / pneumonia for 15%. GI 12%. 9% seizures. Urinary tract infections for 8%. And I see I only have a few minutes to go. And I have to apologize for that. Get carried away with the stories and get so excited. But this is important. Look at the accident and injury nearly equals all of the rest of these combined. And there are many reasons for that, one of which can be a cause for that is hypovolemia. So we have a lot of accidents and injuries related to falls. Very few, although accidents and injuries are low for mortality, they're very high for morbidity with our population. So the American Geriatric Society guidelines, one of the things I'd like to point out to your attention, managing postural hypotension. That is an incredible challenge for our population. Hydration is a lack of basic care. Dehydration is a lack of basic care. Dehydration leads to UTIs because the bladder doesn't empty. It leads to hypovolemia, so patients fall more. It leads to constipation, which leads to lengthening of the colon. Lengthening of the colon leads to redundancy. Redundancy leads to bowel obstruction. Bowel obstruction is the risk for volvulus and unrecognized. This is an ammonia prevention scorecard that I will share with you. Anybody that's interested, feel free to apply it. It'll be in a handout to follow. And this is how to use it. You'll be able to give individuals a score. You can create protocols for when you want to get x-rays and intervene. And this is an algorithmic flow chart for individuals who have where the risk is high, moderate, or an immediate need, low, moderate, or an immediate need of assessment. Now, where vital signs are concerned, they should be emphasized. I can't emphasize enough how important they are. And in the nonverbal population, we have to push for vital signs to be obtained. No matter what it is that you call me about, or a nurse calls me about, I'm eventually going to go to vital signs. We also need to acknowledge pain, level of consciousness, urine output, and weight. This is a rule of 100s that can be used for direct support personnel, so it's not very complicated. You can give them this rule of 100 to know when the nurse needs to be called, when someone needs to be referred. This is important. Respiratory, even 3 to 5 breaths per minute increase over a person's normal resting is an early and important sign of respiratory distress. We don't, how often, when you make the call, do you ask what someone's respiratory rate is? How often do we get a baseline? In a nonverbal population, I want to know if that person is breathing more than their baseline. Can you rely on auscultation? How many times have we seen someone discharge or an annual exam and a cognitively profound or severe individual says respiration is normal? You know it's not normal because they won't follow directions to take a deep breath. And if they're dehydrated, then you may not hear anything anyway. So, but if they do have something going on, one of the earliest signs would be a change in their respiratory rate. Pain, we really need to figure out how to control or manage the pain non-verbally. Now, there's some tools that we can use for that. And this is not one of them unless it's a high-functioning individual. This one, pain scale for cognitively impaired non-verbal adults. You have the opportunity to score it. You can set protocols for when someone needs to be notified. This is a very useful tool developed in the United Kingdom. It's called a Disability and Stress Assessment tool. With this, that for sure. And you can find it online. We'll also provide a copy of it here. What this does, it provides a baseline for you to utilize in identifying when an individual is content and when they're under distress. It will be completed by an individual who knows them the best. And it ranks the person's communication level from unable to show likes or dislikes to high functioning, able to communicate details, etc. So once you have a baseline like this is useful as part of the individual's record for PCPs, for when they're hospitalized. So we can get away from the biases by using objective tools like this that are uniquely designed for the individual. And it includes a monitoring tool for when an individual is recovering so that you can track them for them to get back to their baseline. This also will be part of what we'll be providing for you. So the benefits, increase understanding of the meaning of specific behaviors in the absence of self-reporting. You can assess changes in condition faster and easier. Earlier diagnosis and treatment, better clinical outcomes, and a higher quality of life. This, again, it will be included and is very important. How often do physicians say, either in the emergency room or PCP, well, you're slightly dehydrated, drink more water. We can do better than that because the interpretation of drink more water is all over the board. If we know that the individual standard 31 to 50 years old should have 30 to 75 ml per kilogram, we know that's the baseline. If we want them to have more, then we should quantify what it is and for how long. Increase it to 50 or 60, per pound for 3 days. Follow up with a BU and a creatinine. Chronic dehydration leads to so many of these illnesses, and one of which is the fatal triad of pneumonia, sepsis, and UTI. Pneumonia, UTI, and sepsis. And for those from that last slide to this one, this is how to do the math. So we need to quantify and we need to track input and output based on an actual amount and not nebulous drink more water. Now, what we had here was a wall separating two rooms. It was painted because it needed painting. One individual decided that he liked the wall and he put his handprint in paint and put it on the wall. Well, the immediate response was reproach, of course. And then this insightful individual decided, well, maybe this is not such a bad idea. So I would like to thank you tonight for this, letting me put my head on the wall with yours for the traditional way in which individuals are treated, and we can create something new and unique for this population. by all of us putting our handprints on the wall of healthcare, education, training, and community supports. I love these guys. They were caught up in Hurricane Katrina. The two guys in the blue shirts were in an institution together. They came home after their home was renovated following the destruction. This is what it's all about. And I know I've taken a little more time than probably should have. I hope you're still with me. And thank you for listening. Take any questions, or you can email me. Michael, are you still there?
I'm still there, Dr. Potts. That's right. Anyone?
Thank you for hanging in.
That's right. So anyone who's participating, you can use the questions function on your gray toolbar, and that should allow you to ask any questions you have for Dr. Potts, and I'll relay them for him. Also, if you look in your chat box, I sent the link for the survey. So if you could just copy that and follow that link, that'd be great. If you lose the link or decide not to do it right now, tomorrow in your follow-up email, the link will also be in that. So we haven't had any questions come in yet, Dr. Potts, but I have a question for you based on your rule of 100s. I know that a lot of the patients in the IDD, or a lot of the IDD patients are living in homes, and they might see a nurse or nurse practitioner or see their physician on a typically regular basis. Do you think that it would be appropriate for house staff to get into the habit of occasionally taking temperatures or taking basic vitals, just so they have a record of these individuals, especially if they're nonverbal, having a baseline vital database?
Well, there's probably, we all need to be involved with that. So we certainly need to educate caregivers to know and understand not just what the baseline vital signs are, but also to know what the baseline labs are. Keep a record, keep a file. What's the WBC count, the BU and creatinine? We need to know what these critical indicators are, even respiratory rate, etc. And the PCP, or the primary care provider, primary care physician, should work with the team so that we're all on the same page. Yes, for the home, yes, that will work. Now, there are certainly committed individuals and family members, etc., who can go beyond that in terms of knowing what the actual ones are and track that on a regular basis. And based on that, provide information directly to either EMTs or to their physician, right, to say there's something wrong. The communication tool, the DISTAT tool, is a good tool for that as well. To answer your question, yes.
Right. Thank you. So we have a few questions in for you. What specific assessments and data collection do you recommend for a person who is presenting with potential bowel obstruction?
Well, certainly getting the history. A lot of times, depending on where you pick the individual up, people have a tendency to purge records. Records are extensive. If there's any history that can be obtained of a previous event, then I would advocate for a, I would put a system in place to monitor. In other words, monitor for abdominal distension. The constipation is a significant issue because the physiology can start, or the pathophysiology can start at a young age. And the majority of these happen with the small intestinal volumes, where the increased incidence is there. So if somebody has a history of chronic constipation, then I'm going to be on the alert that this individual could have a redundant colon. Now, at the first time an individual has bowel movements, I would advocate for an intervention to shorten the bowel, or a GI procedure, or a fluoroscopy to identify just how redundant it is. But if it shows up with significant redundance, and the individual is cognitively severe or profound, and has an altered pain threshold, you may not get a second chance. So, chronic constipation, I'm cued in that this individual potentially have a redundant bowel, and one of the risk stratification strategies or protocols that I would follow is have the individual's abdomen examined periodically, and folks be on the alert with a change in eating habits, bowel habits, monitor for abdominal distension, and pain associated with that, or change in behavior associated with that. Does that answer your question?
I think so, yeah.
Okay.
So here's another question. Were all of the data slides with comparisons to U.S. populations, were those based on the same IDD population set?
Yes. No. The blue slide was U.S. population, and the IDD side was the same population. Well, not same as, you know what I mean.
Right.
It was an IDD population. There was a large cohort, and compared to the mainstream U.S. population.
Right.
The blue line.
Right. Here's a good question, and it also relates to tomorrow, which is National Spread the Word Day. So the question is, the title stated AADMD. Can you elaborate on ND and the implications of it?
Well, we're all over the map in terms of semantics. We know what it is that we don't want, and that's the R word. Now,
right.
The alternative to that, whether it's the ID is intellectual disability, ND is neurodevelopmental disability. So some folks just say DD, some say IDD, some say IDND. Whatever the context is that you work in, there's no consensus in terms of which one is absolutely right. That's still a point that's being debated. So.
Right. And I think I also read that neurodevelopmental disorders, it's categorized differently in the DSM, so that when a patient is diagnosed with an ND, that it's not acquired, it's developmental, and you want to prescribe early intervention and early OT and PT to provide these children with as much advanced neurodevelopment as you can. Another question. It's actually more of a request. Dr. Potts, for all of our participants, if you could send me the citations for all of the data you had in your presentation, that way I can send it along to all our participants so they can reference it and use it later to teach others.
Sure.
So another question, how do you balance the dignity of risk, i.e. refusing medical procedures, with preventive health guidelines?
With a lot of diplomacy. It's on a case-by-case basis. So there are a lot of challenges in that regard. Now we've had guardians decide that they were going to have a DNR for many different reasons. Hospitals, physicians do that. I just work with individuals in the population I was caring for directly, and with caregivers and work it out that way. For individuals that I take care of from an institutional perspective, we advocate for as much as we can in terms of life extension and prolongation. I haven't had any, let's say, absolute control over what those outcomes are. Me as a clinician, I will go as far as the system will allow to improve the quality of life and for outcomes for as long as I can. But sometimes those decisions are taken out of your hands by those who have the legal responsibility. And that may not be as yes or no or cut and dried answer, but that's the reality of what it is that I've had to